This recording will go over alpha-2 adrenergic agonists as well as adrenergic antagonists, or the blockers, so alpha blockers and beta blockers. So first we're going to start with central acting alpha agonists. And we're going to talk about clonidine, and clonidine is a selective alpha-2 adrenergic agonist. And if you remember back to when we talked about the different types of receptors, alpha-1 and 2, beta-1 and 2, there was one that's not like the others, and that is alpha-2. So when alpha-2 is selective, and when it is engaged, because clonidine is a selective alpha-2 adrenergic agonist, if you remember, it doesn't work like the others. When that receptor is engaged, it produces hypotension. So clonidine is primarily used to treat hypertension because it causes a decrease in blood pressure when the alpha-2 receptor is engaged. Clonidine may produce bradycardia and sedation at very low doses. Now we're going to talk about adrenergic antagonists, or adrenergic blockers. Most adrenergic antagonists, also known as adrenergic blockers, block either alpha receptors or beta receptors. They block the effects of the neurotransmitter either directly by occupying the receptors and blocking the receptor, or indirectly by inhibiting the release of neurotransmitters such as norepinephrine and epinephrine. Adrenergic antagonists can be classified as alpha-adrenergic antagonists or beta-adrenergic antagonists. Frequently, beta-adrenergic antagonists are simply called beta blockers. So you have alpha blockers and beta blockers. Then they can further be classified as selective or non-selective. Selective meaning they affect only one receptor site, and non-selective meaning they affect multiple receptor sites. Because alpha-adrenergic antagonists or alpha blockers can cause orthostatic hypotension and reflex tachycardia, many of these drugs are not as frequently prescribed as beta blockers. Alpha blockers promote vasodilation, causing a decrease in blood pressure. Orthostatic hypotension can occur with alpha blockers. In orthostatic hypotension, from a nursing perspective, it's a big safety issue because what it is the vasodilation occurs, their blood pressure is lowered, and their body can't adjust as well when the patient moves from a laying to a standing position. So in regards to patient teaching, we want to teach the patient to move slowly. So if they're laying in bed, they should sit on the side of the bed for a minute and then wait a while and then stand up. So not just going straight from laying flat to standing up. That's when the orthostatic hypotension will occur. They'll experience dizziness, and then they can experience a syncopal episode or faint because of it. The two alpha-1 blockers, selective blockers that you need to know are prazosin hydrochloride, and that ZOSIN gives you a hint, the ending of that medication, that you're dealing with an alpha-1 adrenergic antagonist. And then also phentolamine mesylate. And this isn't the first time we've said this drug name. If you remember, we talked about it as an antidote for extravasation of epinephrine or dopamine, dobutamine. So it's an antidote if there's infiltrations of those irritating type medications. Next, we're going to talk about beta-adrenergic antagonists, more commonly known as beta blockers. So beta blockers can be selective or non-selective. And your prototype beta blocker is atenolol. And beta blockers you can recognize because they end in this LOL. So we say, can't think of even what I always say. I always say hypertension. Hypertension is not a laughing matter, and yet the beta blockers end in LOL. So that's one of those suffixes that you need to memorize so that when you see a drug ending in LOL, you can think beta blocker, and you know atenolol, and you know what it does, and you can go from there. So atenolol is special because it is a selective beta blocker. Remember, selective means it only affects one receptor, and in this case atenolol blocks beta-1 receptors only, and it leads to decrease in blood pressure and heart rate, and since it's selective we have fewer side effects, undesirable side effects. And again, I'm taking the test. It's a question about atenolol. I can't remember which receptor it is. I know it's a beta blocker, but which receptor? Is it beta-1 or beta-2? One way to keep those straight is remember beta-1, I have one heart, beta-2, I have two lungs. So if this is selective for beta-1, which it is, it's going to affect the cardiac system. The medication like albuterol, which is a beta-2 adrenergic agonist, is selective for beta-2, right? So we see it being used to treat respiratory disorders. Beta-1, 1 heart, beta-2, 2 lungs. So try to think for a minute, because there are non-selective beta blockers that are prescribed for cardiac reasons. So tell me a population of patients who would benefit from having a selective beta-1 medication prescribed to help bring down their blood pressure or treat their cardiac problem. Who's going to benefit by having a selective beta-1 instead of a non-selective beta blocker? What I'm trying to get at is I'm trying to have you think again about if I bring the lungs in, if I start blocking beta-2, that's going to cause a problem, because if I'm blocking beta-2s, it's going to lead to bronchoconstriction, right? So non-selective beta blockers block both beta-1 and beta-2 and should be used in caution in any patient who has COPD, asthma, any of those severe respiratory disorders. So I do want you to recognize the medications that are selective beta blockers. So atenolol is your prototype. You definitely have to know that one. Here I've listed the other beta-1 selective beta blockers. So atenolol, acebutolol, betoxolol, esmolol, and metoprolol. And a way to remember it is to remember Abe and me. So if your beta blocker is starting with ABE, Abe, or ME, metoprolol, me, Abe and me, those are your selective beta blockers. And again, an advantage of being selective, it's selective for beta-1, less side effects, less risk of bronchoconstriction that would occur if beta-2 receptors were involved. So it's a safer medication for our patients with those respiratory disorders. So looking at these side effects and adverse effects of beta blockers, a lot of them seem to make sense. We're blocking the beta receptors. We're blocking that sympathetic nervous system. So blocking fight or flight, we're going to see rest and digest types of reactions or responses in our patient. So bradycardia, hypotension, fatigue, drowsiness, depression, right? Everything's going to be sort of slowing down because that fight or flight is being blocked. Other side effects, adverse reactions to note: dysrhythmias, headache, dizziness, fainting. Anytime we have hypotension as a side effect, we want to worry about the patient's safety and worry about fainting or syncopal episodes. Got some GI issues there, and also heart failure. You are not required to memorize this information about intrinsic sympathomimetic activity, so you can go ahead and skip this slide, please. Before we get to drug interactions, some things I want to say. Beta blockers are useful in treating mild to moderate hypertension, angina, which is chest pain, heart failure, and myocardial infarction, or MI, or heart attack. Beta blockers should not be abruptly discontinued, but rather should be tapered off over 1 to 2 weeks to avoid tachycardia, hypertension, severe angina, dysrhythmia, and MI. In terms of the pharmacodynamics of atenolol, by blocking beta-1 receptors, atenolol decreases heart rate, peripheral vascular resistance, force of cardiac contractions, and cardiac output, and reduces both systolic and diastolic blood pressure. One thing with beta blockers, students frequently, it's easy for them to remember that beta blockers decrease blood pressure. But an important thing to remember with it is that they also are going to decrease the pulse rate, right? So we don't just want to look at a patient's blood pressure prior to administering a beta blocker. We want to make sure we know their pulse rate also, because that, in addition to the blood pressure, is going to decrease after the beta blocker is administered. NSAIDs, or non-steroidal anti-inflammatory drugs, decrease the hypotensive effect of atenolol. So atenolol doesn't work as well if it's given with an NSAID. Increased effects of atenolol are seen if given with prazosin. And when you see that ZOSON, right, so you don't even have to know that drug name, because you should be able to recognize the Zosin. Prazosin was your prototype med of which category? Hopefully you're thinking alpha-1 blocker. So we'll see increased effects of atenolol or a beta blocker if taken with an alpha-1 blocker or with atropine. And atropine is an anticholinergic. There's an increased risk of hypoglycemia when the patient is taking insulin or sulfonylureas, which are oral diabetic medication.